You should be in the room for Back to Basics antimicrobial stewardship programs in long-term care. So if that's not the room you're supposed to be in, you may want to exit at this point in time. We have a number of wonderful speakers for you today, so I will do some brief introductions now. First, Dr. Mahajan is President and CEO of CIMPAR. He is the Clinical Associate Professor of Medicine at the University of Illinois at Chicago and Faculty in Geriatrics Fellowship at Loyola University Health System. He's a fellow of the American College of Physicians and board certified in internal medicine and geriatric medicine. Additionally, Dr. Mahajan is a certified medical doctor, a certified physician advisor in utilization review and healthcare quality management, and is certified in infection control and epidemiology. He is a nationally recognized speaker on healthcare reform, MACRA, MIPS, APMs, post-acute UPPs, and post-acute and long-term care PALTC medicine, and transitional care improvement. Dr. Mahajan chairs AMDA's Quality Measures Committee and leads the Population Health Work Group of its Public Policy Committee. He is a pioneer in developing PALTC population concept and has been the leading force behind developing meaningful quality measures for physicians practicing in PALTC space. His areas of interest in research include infection prevention, antimicrobial stewardship, and psychotropic use in PALTC. Additionally, we have Dr. Rajiv Shah. Dr. Shah is the Antimicrobial Stewardship Program Coordinator and Research Associate for CIMPAR. He is the content creator and presenter for all stewardship-related activities. He also works on research projects related to antimicrobial stewardship and creation of content for long-term care and acute care. He is a medical school graduate and holds a Master of Business Administration with emphasis in healthcare. He has been actively working with the CIMPAR antimicrobial stewardship team to organize, to conduct, and to educate providers on antimicrobial stewardship activities throughout Illinois. And then finally, flip to the appropriate page. We have Sylwia Jasniuk. She is a dedicated nurse leader with a background in clinical innovation, patient care, and healthcare management. With a proven ability to identify and to implement innovative solutions, Jasniuk enhances patient outcomes, drives process improvement, and optimizes healthcare delivery. As the Director of Therapeutics and Clinical Innovation at CIMPAR SC, she spearheads strategic initiatives, oversees grant implementation, and manages mobile services and therapeutic efforts. Jasniuk's expertise includes collaborating with cross-functional teams, managing complex projects, and fostering a culture of continuous learning and innovation. Her nursing career began in the intensive care unit at Illinois Masonic Medical Center. She holds an accelerated Bachelor of Science in Nursing from Loyola University and a bachelor's degree in biochemistry from the University of Illinois at Chicago. Please help me in welcoming our speakers up to the podium.
That's almost our time, so 5 minutes into it. And okay, thank you everyone for joining. I was again from first year since we started doing this 10 years ago. Been part of this and have seen from maybe 10 out of 200 people at the first session from LTC to literally a sold out room here, and majority of people choosing to be in this session, and also more than half of people who are registered are from or at least associate themselves with post-acute long-term care nursing homes. So really a big win for us in stewardship. We want to learn. Big hands for everybody who's here. Again, if you can't tell from my excitement and that from this morning, that it just still makes me very, very excited and emotional when I see the group here wanting to keep going back to basics, right? And so, we saw research papers, we talk about these fancy quality measures, but then every year when we ask our people, what do you want to hear at the summit? We want the basics. Tell us how it works. We all want to do it, and I do think, as we saw from the data, that pandemic did stop us in our tracks on this important issue. And so now we're going to go back and hopefully just talk about how to do that classic stewardship work in post-care long-term care session. Next slide. These are our tender profile pictures. So anybody interested? Getting next. So those are learning objectives. Again, is in the handout. We can just talk about just the basics, some regulatory material around it, some challenges that are that we face in starting and maintaining these programs. And so you will see in upcoming slides. And next slide. So just definition. How do you define stewardship, right? So anytime we do, folks are jaded and say, oh, you talk about stewardship because you don't want to use antibiotics. Or you don't want to give, there's costs associated. And those are all real facts. So we say that almost 70% of antibiotic use in nursing home setting is either inappropriate or excessive. So that is a staggering, data element that we have. So the definition is not don't use antibiotic or use antibiotic. It's how do you appropriately treat infections while cutting down some of these high complications or adverse effects we have from inappropriate use of antibiotics. That's stewardship, right? So we're trying to be stewards to our patients, our residents. And so it truly is appropriate infection treatment while reducing the side effects. So how did the regulatory environment, how did the need of this work come around and how did we get here? There's some timeline there. There was some initial studies on, again, over 50% of antibiotics in long-term care are inappropriate. Over 50% are used for longer duration than they should have. Over 50% are the wrong kind. And another big factor is that 80% of antibiotics in nursing homes are used by 20% of the providers. So there is that gap. Based on all of that information, in 2014, there was a call to action from White House. And again, a lot of us were, when I say us, the professional societies were there. President Obama, his administration, presented all that and their plan. And based on that, in 2015 is when the nursing home core elements. We talked about core elements, we'll talk about it again. And were published by CDC, Dr. Namali Stone, who's been here at the summit, I think back in 2018. I call her it's just a pleasure to have, met her, worked with her, and for her to be here and talk about. She was the main force behind nursing home core elements stewardship, published on CDC website in 2015. And again, Joint Commission, they came up with their standards. The folks that are Joint Commission accredited, they have their own set of antibiotic stewardship standards. And next slide. So again, that's where everybody's eyes get wide open. What is that, right? And I talk about for folks that were in our workshop in Chicago, again, it was in Oak Park, but our Chicagoland conference, and towards the end, there was this. I got very emotional because it was good to see a big group wanting to know why we do it. And I asked that question, open-ended question, like, why are you here, right? And so, is it that? Does anybody want to take a stab at what's it's four letters up on the screen? What do they stand for? Anything that starts with F and is 4 letters is not good, right? So. And so, so yeah, what did someone say? It is on a biosolution. So, okay. So it's under a code of federal regulation. I think it's 483.3, which is nursing home regulations, infection control. There's a FTAG. And this F8881 is when the regulation around antibiotic stewardship and surveyor guidance, and they find something. So that is the citation that you get for not having your antibiotic stewardship program as per the regulation. And so, and towards the end, we'll come back and talk about how do you get a compliant, regulatorily compliant program, and that is really how do you write a policy. And so, and I'm going to call you out. Thank you for coming and being in front. And so for saying how sometimes things work, right? So if the goal is to not get a citation, you can achieve that goal. But if the goal is to see why the regulation was in place, and truly do it for the right reason, which I always say is that if you or your loved one had that C. diff because of inappropriate or incorrect or not needed antibiotic, I have seen people, no matter what you do, die, right? And before they die, they might have that resistant C. diff spread to more people in a nursing home and have a unit full and things like that. And it's very hard to be that resident, that family member who actually ends up having it. So doing it for right reason, because you want to do what's best for folks in nursing home, is the reason why we do stewardship. Being compliant with F881, which is the stewardship regulation, obviously is something that in our healthcare industry, you have carrots, you have sticks. We end up doing sticks a lot more than carrots, but Jamie talked about having an honor roll, right? You do the right thing with a tap on your back. That should be also the motivation to do it, not to have a citation that you have to do a plan of correction. So, and again, I get, a little bit kind of worried with this because that is really the message we want to get through is do it for the right reason. And so, not the 4-letter word with F in it, really do it for the resident. Next slide. And so, so truly, we talked about the core elements, and Sylwia's going to come up after this and show us, I think, when we started, there was a QR code, which was a gap analysis tool, right? So as I said, in 2015, these 7 core elements were released, right? And it starts with leadership commitment, and after that, accountability, and then there's expertise, and then there's action, then tracking, reporting, and education. They're all 7, right? So when you go, like for folks, and I want to be very confidently saying that most of the nursing homes are somewhere when it comes to a stewardship program. But we did informally survey because when we were making this session, we wanted to actually have some model programs come in and sit next to us and talk to us about how you do. And COVID just did a number. I remember pre-COVID, we were there when it came to core elements and where people were. And we used to call it the crosswalk. There was a nice saying, what you're doing, this is a crosswalk, fill up this form. We were here in 2017 or 2018. Everybody got that form, they filled out. They were somewhere on that track to have a successful program. And 4 weeks ago, when we made those phone calls, a lot of people have regressed, right? And they have so much other, I'm trying to not use an R word, R-rated word, but it's they've gotten so regressed on stewardship because there's so much on their plate, we weren't able to have. And so really, that gap analysis tool, as you fill, will give you an idea as to where you are with your program. So it's literally asking you questions about core elements, and so I'm going to have Sylwia come up and quickly show you a quick demo of that. And the good thing is not a paper form. It's not just an Excel spreadsheet. It's something that that you can follow along. Sylwia, I'll give it to you. So you can, that really tells you where you are at the facility when it comes to stewardship. And it's real, and it's not something that stays on somebody's desktop, and then it goes with them if they go somewhere, or if the desktop dies, that every progress you've made. So it is something that is yours. You can go ahead.
All right, so I'm going to drive it up here, but I see a bunch of phones out. I love that. Go ahead and follow along with me if you'd like to.
Oh.
There we go. Technology, right? Pull it up. All right, so we obviously talked to this morning also, like, how do you know where you are? How do, I guess our time just got a little bit shorter. How do you know where you are? How do you keep track of your progress? You know, you've got all the core elements, but what about them now, right? What do you do with them? How do you know, especially if you're just starting out or you're in the early stages of your program, or maybe you're a couple years in, but you know, there's been staffing changes. You don't quite know where to begin to assess where you stand. We've developed a tool that will kind of help us along with that. So we've got, we start with just a couple of things. We're about your facility. We're living at Shady Pines these days, right? Appropriate. And then it'll ask you under 10 different categories, a multitude of questions. And it's going to make you reflect about what the antibiotic stewardship program looks like at your facility right now. And the best thing to do about this is just set aside some time and go through every single one of these. And, you know, as you answer more and more come up. It seems never ending, but it's really going to make you reflect about where you are. And it's also going to give you a direction into where you need to start looking. You know, if you're possibly, I'm going to imagine that many of us in this room have less than maybe 3 years, less than 1 year of experience in infection prevention. I see a lot of nods out there. You're going to need to find a direction into which you're going to head to, and you're going to need to identify the places where you're lacking, where you're doing really well, and this tool can certainly help us. Audit this one, and once you fill that out, Shannon's still collected. But once you fill that out, that's basically going to take you through those 10 domains, and it's going to point out which domains you're really lacking in, how much you're lacking in those domains. And if you look through that second link, you're going to be able to pull that out from one of our facilities. And you're going to be able to identify some places you can attack first. Maybe it's the ones that seem more accessible to you. Maybe there's some education you can go ahead and do first. Yes. Unfortunately, it's not. It's the link, but if you are able to scan this one, it'll open up. And if not, then we'll send that out to you. Or if you'd like, you could certainly fill out the first one and we'll be able to get you your results to you. And it's going to be really interesting to see where you are. And ideally, as you implement all of your measures, as you strengthen your antibiotic stewardship policies, 6 months from now, you do this again, and you're going to see major changes. And you're going to be able to identify more areas into which you're going to seek improvement. You know, perhaps what you're really lacking is some support from your physicians. We heard a lot of that this morning. And maybe that's the one that you want to tackle where it's going to make the most difference. So really kind of understanding where you are, having a good tool to assess that, and then being able to take action from those tools, I think is very important. And hopefully you would be able to utilize this or similar tools to be able to do that.
We will. There is a list of folks that are signed up for this. We will, and this is part of our ongoing work specific to long-term care. And so this is to share. It's not, it's the only thing is it's got incorporated into the presentation relatively last couple of days. So not sure which version of our presentation is on the USB drive, but it will be shared with everybody. And whoever is interested right now, maybe just give us some time after the presentation, we'll share that with you. We've got a lot of material to go through, and we definitely wanted to use this. And one more tool that is kind of practical from this is to assess where you are currently, so you can have your high priority areas on the program. And then there is a case report tool that's coming up also that really takes a lot. So the problem is, because a lot of things are being done on paper and papers get lost and it's very hard to have everything in one place. So we're trying to have it all centralized, and this is your information stays with you because you will have. So here's what the gap analysis once you fill up looks like. And this is also a side-by-side comparison that we can do on how the dashboard looks like on the stewardship. So next slide. And then over maybe next 15 to 20 minutes, we will go over after doing this a very foundational where we go core element after core element after core element. Having done that for 10 sessions for the whole year, based on the feedback, there are some things on those core elements that were just so much needed and asked for. Rajiv is going to walk us through some of those things that are very practical that you go home tomorrow to your facility and you want to start doing things. We're going to discuss those things.
Thank you, Sylvia. Thank you, Dr. Mahajan. So yeah, as Dr. Mahajan mentioned, we've all visited and revisited the core elements multiple times in our facility. But what are the most important things that you want to get out of the content of the core elements? So some of the things we'll just dive a little superficially, but a little deeper as well. One of the things that is very important for any facility, especially a long-term care facility, to have is a leadership statement support. Now, what your leadership team consists of is independent of this, but that leadership team could consist of a medical director, the executive leadership team of the long-term care facility. And what they really need to do is establish the support system as well as the objectives and goals that you are as a facility trying to accomplish for your patients as well as your staff. So in a statement support, you can include some of the several things that are mentioned here, outlining the duties of the ASP team members. What is the code of conduct? What are the things that you want to manage, create, and control over in your ASP program? Communicating expectations between your staff members, from your nursing home staff to just your staff members within your facility. And lastly, creating the culture that will promote and establish an ASP program for the future, not something that's more temporarily. So the next core element is your accountability. As Dr. Mahajan mentioned, and we've visited this earlier in the sessions as well, that accountability is key. Having a good team around your leadership executive team is very important, but having individuals be accountable within that group is necessary. Why? Because they can establish the goals and objectives for your team members. Example, the people who can empower and be the leaders of the program could be a medical director, director of nursing, as well as the consultant pharmacies. What we've noticed, especially while we did our workshops last year, is a lot of the rural hospitals, as well as the long-term care facilities, a lot of them do not have the resources to establish and have an ID physician on staff. So the utilization of a consultant pharmacist and them being accountable for that group has provided significant differences within the hospital system. As well, it's clinically proven that they have decreased the amount of antibiotics used and decreased the unnecessary use of antibiotics as well. So how can you establish accountability? Use the support statements, and what can you do? Developing expertise within the facility, as well as it helps you partner with experts around the community. Now, for example, we'll take the consultant pharmacists. They're able to receive specialized infectious disease or infectious disease antimicrobial stewardship training. Many of the consultants can, receive education specified for antimicrobial stewardship activities within their element. Also, antibiotic stewardship programs within the hospitals can have a referral network within the area, especially the local environment, that could coordinate and communicate with other hospitals or long-term care facilities within that area. So you might consider, what are the essential things to form an antimicrobial committee or team? So required versus optional. The required definitely varies depending on the facility and the resources that are given by the executive team. But some of the individuals and partners could be infection preventionists, a medical director, or designated lead physicians. In a hospital setting, for example, or even in a long-term care facility, you might have a hospital medicine and doctor conducting the antibiotic stewardship program, the director of nursing or assistant director of nursing, and again, a consultant pharmacy is necessary. A lot of the long-term care facilities do not have a consultant pharmacist in-house, but utilizing the outpatient pharmacy as a consultant pharmacy as well, that is of most importance. And individuals that could be optional or definitely have impact within your stewardship team are the administrators, prescribing, any other prescribing providers, attending physicians, could be nurse practitioner or physician assistants, any nurse aide representative or nurse representatives, any other allied health professionals, such as occupational therapists or physical therapists, as well as representative from the family and the resident who's being treated. So what are the tasks and what are the specific responsibilities of an antibiotic stewardship committee? So first, as we spoke about, establishing that support statement is extremely important because it lays down the goals of the team members. So again, support and promote the antibiotic use protocols. Again, developing a system that works for everyone and it's easy to maintain for your program. Something that all the providers can relate to, they singularly are able to efficiently get the information they require in order to create and maintain a good program for successive months as well as years. Report antibiotic use and resistant data regularly. This will definitely help because we'll look at the next few slides of what essentially helps with collecting data. That data could be established and retrieved from your consultant pharmacy, or you can even retrieve some of that data from your EHR. And lastly, providing education on stewardship activities, as well as providing education to prescribing providers and nursing staff, because it adds the resources to your residents as well as family members. So we'll take a quick poll. So if you would like to get your phone out and either use the URL that's on the top, it says pollev.com/QWER, or you can text the code QWER to 37607 and answer this question. What we're trying to do is gather information to understand what the crowd generally is, especially in this question that mentions, do you use an antibiotic timeout at your facility? If you do, you can answer yes. If you do not, please answer no. I will give everyone a few seconds. If you have difficulty pulling up the poll, please.
So the easiest would be using your cell phone, and for the phone number you're sending it to, just 37607. 37607 is the recipient number. Yeah, 37607. Just say yes or no to that.
Well, first you guys are clear.
Yes.
And we can always, in respect of time, go old school and do a show of hands. Can you, is that going through? Okay. All right, Reggie,
It's just buffering, yeah.
yeah, you can close it out and see if we have responses. I think some people said it went through. Okay.
Yeah, it's
Close it out.
just buffering. Okay.
Okay.
It's just buffering.
Then we will, I know, just in, a lot of times when you do that, there's a funny practice question which we skip because it is pretty common now to have this, but I do understand. Do we have responses?
No.
Okay. All right, so, old school, the question is, do you use an antibiotic timeout at your facility? Yes, is a raised hand. All right. Hands down, you don't use antibiotic stewardship at your facility, right? I'm sorry, you don't use antibiotic timeout at your facility, right? Okay, third question, you just don't raise hands anyways. All right, so there is, as expected, we don't use timeout at our facility was a decent hands raised. And there is the reason why we put this. So again, going back to if we were in an acute care session, that would be considered pretty much standard, not the exception, where if you were in an acute care setting, what timeout means and whether you do it, almost all hands go up saying yes. Now, how you're doing it is different. Whether it's an inbuilt hardwired in your EHR, so you have picked your CERN or your Meditech, is the question. But here, so we do have several EHRs. So we have PCC, we have Matrix Care, we have AHT, we have NetSmart. There are several, 4 or 5 EHRs that are there. But whether the antibiotic timeout, which I'll take a pause and ask for a volunteer to say what that even means. Is anybody willing to share that? So that's what does an antibiotic timeout mean? What?
That popped up during the use of it, and also tracks up the time, so you're verifying that it really need it for some days versus 3 days, what their symptoms were prior to the antibiotic, what they were after, which I can.
Okay, fairly close, almost 99.99% accurate. So the timeout per se is, it's a sports analogy. However, timeout is when infections are suspected. We don't, or we might not have time to really make a lot of decisions and start an antibiotic, right? But we know stewardship is all about using the appropriate antibiotic, whether it's the type of antibiotic, whether it's the route, which is oral, IV, topical, or how long you're going to use it, and what are you treating? You might not have all that information when you started, but once you started, there's something called a timeout, which could be, a lot of times in hospitals, 48 hours, and nursing home could be 72 hours, but by that time, you should have the information on what you're actually treating. And what you have, is it appropriate or not? And if it's appropriate, how long you're gonna treat it, and do you have the infection test which you did, whether it's a culture, whether it's other confirmation. And so the timeout is when you start an antibiotic, and then you take time to see whether you want to continue it, how long you continue it, what kind you're gonna change it. So there's a lot of things that happen. And so that moment when you have started an antibiotic because you had to treat that, what it looked like an infection or certain infection, and then you do that, and then that's when we make a decision, timeout. So again, of 3 things I can have you go home today and say, we're gonna do better with antibiotics. The right thing with the antibiotics, timeout is item number 1. And so for half of the nursing home people here that raise your hands, you don't have timeout, is where we're gonna talk about how to do it, right? So you have to have it. So it is a team effort. And a lot of time it's your infection preventionist who is the champion. And if you don't have electronic health record, that really gives you the power to automate that process. So if I'm in a hospital, for example, I go see a patient, I'm making rounds, I log in, it doesn't let me do anything. Says, do you know your patient was started on Rosefin 2 days ago? Do you know what you're treating? And do you know how long you want to treat it? You want to continue Rosefin, or you're going to change it to something else, something oral? And so unless I make that entries, the system does not let me go any forward. I can't even, order a suppository, right? So, and it has patient with pneumonia, right? And that's the power technology that can help you, but we know in our long-term care, we're not there. So it is going to be a manual process. And I know, this is an important thing. And that's an even split right there. Sadly say, almost half of the people don't do it. So that is something, again, a plug as we continue this work. Folks that are here, folks that said we don't do it, stay tuned. We're gonna have 1 session, both in person as well as online, dedicated to antibiotic time. How do you do it? What's the process? And again, in between sessions, we will discuss that, but truly it's a process where you're monitoring the use, and at that 72-hour or 48 hours, whichever you pick, you sit down, look at all the information and decide whether you continue it or not, and go ahead.
Thank you, Dr. Mahajan. Sorry for the little technical difficulties, but we'll continue on. So again, as Dr. Mahajan mentioned, all those goals are to be determined. And this is what a template of an antibiotic tool looks like. Again, it's also called the SBAR tool. What an SBAR stands for is your situation, the background of the patient, the assessment of the patient, and the recommendation. So again, we will be speaking about this a lot more in depth as we get along with our new initiatives with the ASP program. So we'll take a poll again, and I know too many polls here, but if you guys can, hopefully this one would work a little better than the last one. So, okay, it seems to be working well. So we'll give everyone a few seconds here. So as we're getting responses right now, I'll let Dr. Mahajan say a few words.
That's fairly accurate. I do expect this to land around 75, 25. 5 people, 25% of people saying, yes, we use it, and 75%. And then when we further did that, 75% people might be, a fair majority might be associated with the health system, where they might have a hospital as part of their. And so if you're a purely post-acute or nursing home facility group or individual facility, almost 80% of facilities will say they don't have an antibiogram. Now, again, item number 2, if I were to go home tomorrow at the nursing home, infection control person, administrator, and would have to achieve a second thing. First thing was a timeout, the second thing will be an antibiogram. I don't expect you to have an antibiogram tomorrow, but at least know what it is, and see where to get it, right? So what is an antibiogram? Again, anybody, from a nursing home wanna tell us what an antibiogram is?
To what antibiotic area based on your lab are most appropriate.
Okay, so if cheat sheets were illegal and the right thing to do, and I mean, they didn't tell me during high school exams, but so that is your cheat sheet, which is the right thing. So it should be, it shouldn't be called cheat sheet, but that came to so you know what are your common infections, and what are your common bugs, and what are the antibiotics that work for that kind of infection. It is from the evidence that you have. So that is an example of what it might look like. So it is a collaboration between your laboratory, and your pharmacy and your people who are working within the facility in tracking those infections. So it sounds like a fancy word. Your laboratory, the microbiology laboratory, should be able to compile that information for you and give you. So antibiogram is literally everything. So when you say, can I get my microbiology result, a lot of time labs will bring you a year's worth of every single lab, say here's what you asked for. So can you please compile that, tell us what UTIs I had, what pneumonias I had, and what kind of bugs we got, and what kind of antibiotics work for them. That can be done. Most of the laboratories have the ability to do that for you. Some of them might charge you for doing that, but it's not. I've heard anywhere between $50 to $250 per antibiogram created. And it should be specific to your facility, but as we know from our knowledge of statistics, that if you only have a small facility and small infection, that information might not be as reliable. So we do talk about regional antibiograms, which could be your hospitals and nursing home, or just a group of nursing homes together. And so there is a way to get that. And again, the last thing could be if you don't have the ability, or the lab is not willing to work with you, or you have so few, it could be you could just for reference use your neighboring hospital antibiogram. Again, as we mentioned, it is fairly standard in hospitals to have antibiotics. So it at least gives you somewhere to start, but as you move forward, you can work with your lab, your infection control people together to come up with that. And the next slide or so, we will show how it can be created by you by getting those basic data elements. Rajiv.
Yeah, so just switching back to the previous slide, as you guys were, as Dr. Mahajan was mentioning, if you look at the chart itself, it's subclassified into different categories. So the top row most likely always specifies the class of the antibiotic. Below that is a type of antibiotic within that class. So if you have an aminoglycoside class, then you would see a name of an antibiotic such as amikacin or gentamicin within that class. On the left of that, in the beginning, before the beginning of the type of the antibiotic, you'll see the bacteria isolates normally. And on the left side, you will see the name of the bacteria itself. So here, if I can just point my laser pointer for a few seconds. So here you'll see the bacteria type. Here are the isolates of the patient count. And you might be looking at this and wondering what these numbers are. So these numbers represent the susceptibility of this bacteria for this antibiotic. So what does that mean? Well, if you subtract, for say, suppose 92.3 for Klebsiella, tobramycin, if you subtract that by 100, that gives you a 7.7% resistance rate for that bacteria with that antibiotic. So this is how helpful an antibiogram is exactly. And creating one, like Dr. Mahajan mentioned, creating one for your facility, you can have a facility logo, it'll give you a susceptibility chart. You can input information as it comes from your EHR or your consultant pharmacy, whichever one that you use. So again, benefits of this, very easy and simple to use, and you can create one for your facility. And then some of the challenges you might receive is if the resident does go from one facility to another facility, it doesn't really help because it's facility specific. Another thing is, creating an antibiogram for a patient for a longer period of time could be maybe it's not cost effective either. So there are certain guidances that can be used. Example, maybe helping use infection specific antibiotics using the antibiogram while the patient is or the resident is in the facility. That is very, very important. Again, intrinsic resistance of some of those bacteria to specific antibiotics could possibly not be listed within that antibiogram as well. So as we move on with our core elements, we'll take a look at certain things that using that antibiograms can give you specific data about the medication that could be prescribed. But as far as reporting tracking tools that we can use, what are some of the data elements which are important within that tool that can help you guide patient care? So some of these are obviously the more common ones are you see here is the resident's name. Again, the prescription, again, the drug, dose, route, duration, all those are needed within your tracking tools. Naming of the antibiotic as well as the class it relates to, knowing the days of therapy, when was a start date, when was the end date, those things are specific to the tools as well as reporting and tracking, route of administration as well as resident days. So when you use certain antibiotics, these antibiotics are specific to their protocols. So again, going back, we understand that the requirements of using these antibiotics should be specific to the patient as well as the dosage, the duration, the route, and the indication of all antibiotics should meet protocols before administration.
So as that of 3 items, item number 2, the antibiogram. Item number 1 was antibiotic timeout. And folks that you think you're ready, we answer emails is asp@cimpar.com. There will be a dedicated session, both in person as online, coming soon. Same thing for antibiogram, how to create. I know a lot of information, we keep saying it's very easy. It's not, till you start getting that information. Those forms are available as you try to populate that. That will be item number 2. If we can do it to make sure everybody knows that there is an antibiogram we have and that we disseminate to our providers so they use appropriate antibiotics when they start. The tool number 2 that we talked about, so just again, can walk us through that, a live demonstration so you know it is real. And after that, until it's going to continue with a couple more items. So of the 3 things, antibiotic timeout and antibiogram number 2. So.
Okay. We've got this one up. Awesome. So I'm a data kind of gal. I like to know exactly why I am wasting my time every single day trying to figure out things and where in the world I should be wasting that time. And this is going to be a great resource for you to be able to allocate your time in a way that is most effective. So here at Shady Pines again, we have had record low number of only 80 infections this year, which we have put in through this therapy entry form. This entry can be done really at any time, but ideally it kind of lines up for when you do that antibiotic timeout because all of that information is already there. And what you're ideally doing is putting all of your data, all of your knowledge on this topic for this program in one place. So you can have it somewhere where, it's not on a paper form and it disappears with the last IP or somebody lost a binder, or maybe your EMR or something, you no longer have that dashboard. And B, because you want to be able to put that sleuthing to work for you so that you know where to dedicate your time. So we've submitted 80 records and 64% of them over the year have met criteria. Is that a good or a bad thing? Can anybody tell me? We've kind of got a mixed reaction here because it's both. It could be a good thing. It could be a bad thing because you don't know where you were last year, right? And that's kind of goes along with tracking your progress. Again, I'm a numbers kind of gal, and if you don't tell me how I did last year, how I did this year, I'm not going to know if I'm supposed to do better next year or if what I'm doing is working. So 64% of that, it has met criteria. Hopefully that's better when we look at this next year. But then it also tracks all of our infections because we know not all of our infections do require antibiotic treatment, right? I think lice is one of them up there. Technically an infection, but we're not giving anybody, antibiotics for lice here. And you can also visualize what most prevalent infections you have. So UTIs here in blue, you can tell that possibly are we overdiagnosing UTIs? That's something that can show you a good direction into which you can head. That way you can identify why only 64% of your patients meet criteria for treatment. And you can even come back to it on a month by month kind of analysis, right? We had some pretty low scores here in the beginning of the year. So we did some education. We contacted some of those prescribers. There's 2 of them maybe that just, like we said this morning, somebody is ordering antibiotics with every single urinalysis, had some stern emails back and forth, and it resulted in much higher rates of meeting our criteria, which is awesome. And then our days of therapy per 1,000 resident days are also shown. This one's really nice because whether your census goes up, whether your census goes down, you're able to track your progress also. So this one is just a quick overview of some of the elements that you can keep tracking. Using some of the tools that are out there, making that technology work for you rather than you having to, sort through all of this. And then where are you getting all of this data, right? You're filling out your timeouts, but, unlike me who gets to make up de-identified data just to have these presentations up there, you don't get the luxury of making it up. But you can find it with your pharmacy. They're going to know how many antibiotics you've ordered. They're going to know, the classes, the diagnosis, the providers. They have all of that in their system. They can provide that to you. Your consultant pharmacist can also help you determine if those orders meet criteria or not. Loeb's criteria, McGreer's criteria, whatever it is that you have established in your policy to use, they're going to be able to help you determine. Your laboratory is going to give you that amazing antibiogram, or they're going to help you create your own if that's something you want to set out to do. And of course, your IP is pulling all of this together and, being able to suss out, what you can tackle. Broadly, just your measures, you're looking at those antibiotic starts and days of therapy over 1,000 resident days. For your processes, take a look at whether the documentation is being filled out, whether you do have something to take a look at. And of course, your measures, see year over year on your antibiogram if your resistance is going up. Do you have things that are less susceptible now? Your antibiotic associated adverse events that you should be keeping track of. And of course, ever present C. diff infections, trying to get those rates down. You should be reviewing this periodically. Ideally, on a monthly level, you would be looking at those timeouts, looking at a month-to-month change. It is required that you conduct at least an annual review of your antibiotic use data and your policies, and that you provide this data to your QIs regularly. Of course, keep the same track of your resistance data, making sure that you're looking at that antibiogram year over year and contacting your laboratory. And making sure that this program is part of your larger infection control program, and it does reach your QAA committee at least annually so that the whole facility can come together and discuss those. Education at minimum, your staff should know that there is a program in place, there is a policy to be referenced, and that each healthcare worker is responsible for ensuring its implementation. It's not just the responsibility of the committee that it gets done, but that everybody in the building participates in the implementation, and that the residents and their families know what's going on too. There shouldn't really be any surprises when we come and have these conversations about whether you're getting a Z-Pack for your cold, about what the policies in that building are. So make sure that your residents know that, you know, there are dangers of misuse and that we are actively trying to prevent that.
So thanks again. I know we touched through the last few slides. We wanted to have at least 3 to 4 minutes open for open discussion. There was a polling question, and Rajiv, if you want to reset it, we can still do that. And just going back to having a appropriate policy and the procedures that go with it. We asked for it. So although with the new regulations, the mega rule that, you know, it's almost 6-7 years in place now, the stewardship part of that has been live since 2019, right? And so there have been regulations where nursing facilities have been having surveys on, and during our presentations last year, I was surprised to hear that a lot of people, infection prevention folks that are in the room here attending, did not know they had a stewardship policy. And then we go back to the F881, that is you know, having a policy and what you do around it, having that written up is what 881 is all about. And so so we did have one of the workshop where we had people bring their current policies, and a lot of people had to go back and go to their you know, the binder that comes from the trade association, right? It comes in, gets stamped for your facility, and gets put in. And so it was a lot of learning. People realized, so you could have a simple 3-paragraph policy, or you can have an extensive 5-page. And I think as we talk about that, you know, most people kind of fall in the middle where you really have things lined out that you've identified that are specific to your facility. And truly, why do we have the policy? Again, not to not get the citation, but the policy is because we want to have appropriate use of antibiotics while we reduce the side effects and the adverse effects that we have that can cause patient harm. So a lot of regulations. So even we have the F757. What's that? What is F757? That's inappropriate medication use, right? So and that's the question. How often do we have to review our stewardship policy? Any volunteers? I thought it was D or E when surveyors walk in the building. So the question is a little tricky. It's a little tricky, not tricky on the surveyor part. Dr. Kennard is looking at me. So it's annually and as needed, right? So the annual part we all know, but what is the as needed part is that a lot of people have hiccups with. So anytime there is, when you have your dashboard, when you have your infection control or infection prevention related monitoring, anytime you have seen trend that is not going in that direction, or you have a hospital send out, or you have a HAI. Anytime you have that, should be a trigger to look at your policy, not just because you're getting ready for an annual survey, you should be reviewing your policy procedures, that's you should be doing. But anytime you have that change that affects your resident condition, there should be a trigger to evaluate your stewardship policy. I think with that, we're going to give you exactly 10 seconds for questions, but that's us. We'll be here. I know there might be a few-minute break, but we'll be more than happy to stay here and answer questions. But again, you guys have been extremely patient audience. I know we went through a lot of information real fast, but we'll be here. The email is here. We'll continue this work throughout the year. Thank you very much.
It's turned off. It's turned off. It's turned off. Right there. Right there. Yeah.
And as you're walking out, if you want to see us in Rockford, Naperville, Springfield, or Mount Vernon, we will spend an entire 2 days in each of those cities going on a deeper dive to every single one of these topics. We've had an hour here, but we'll have about 6 over there. So please join us. And hopefully we can kind of deep dive on each one of those things.
Sylvia.